Hello again, it's Professor Brown Kishbal, and we're going to take a look at complaints in the gastroenterology system from a diagnostic approach. Learning objectives are going to understand the common complaint, diarrhea. We're going to identify, understand, and interpret the common laboratory and imaging for the diagnosis of diarrhea, and also apply diagnostic reasoning in that process and understand the differential diagnosis. When we look at diarrhea, we do need to differentiate between acute versus chronic, and that does have a lot to do with our time frame here of less than 14 days, more than 14 days, or more than 4 weeks. When we look at acute diarrhea, causes such as bacteria, virus, or parasites, and then certain medications, and really anything that can cause diarrhea. When we get into the more chronic diarrhea symptoms and etiologies, we're looking at inflammatory. Is there more of a osmotic situation within a sensitive enteropathy present? Is there a secretory genetic issue such as Zollinger-Ellison, villus adenoma, or is there disordered motility? So those would all be the differentials. Your first decision tree point is going to be acute versus chronic. So when we look at the definition of diarrhea, we're looking at clinical presentation of more than 3 stools daily, and they must have a liquid or loose consistency. Stools that are more frequent for the patient than normal and more in the last 14 days would be also consistent with that definition. Stool weight, at home, you're not going to be weighing your stool, so this would not be for the outpatient scenario. This would be more for inpatient scenario. Duration we already discussed. So urgent considerations would include anything that has volume depletion or electrolyte disturbance as a main concern. Other things would be if there's a perforation or toxic megacolon, intestinal obstruction, or sepsis and bacteremia present from other organs that are making the complication of diarrhea. Etiologies, again, we have celiac, malabsorption, viral, bacterial, parasitic, iatrogenic, which would be related to meds or radiation, and then our inflammatory disease processes. Many patients will not present until they are out of the mild to moderate. They usually present if they're moderate to severe. A complete workup is warranted if there are bloody fevers, severe abdominal pain, volume depletion, or history of inflammatory bowel disease. Acute diarrhea can be classified as watery or inflammatory. Watery is going to be small bowel involvement with large volume, and this is usually associated with abdominal cramping, bloating, and gas. This is usually related to some type of virus or bacteria, or it can be related to various food intake issues, restaurant outbreaks, cruise ships. Inflammatory diarrhea is typically from the large bowel, and that's going to be small, frequent, regular volume stools, can be painful, and may have a bloody or mucus component. Salmonella, Campylobacter, Shigella, enterohemorrhagic E. coli, Vibrio. If it's not infectious, then that would be related to inflammatory bowel or possible ischemic colitis. What are the key questions that we need to ask? So, those pertinent historical clues would include what type of foods or juices or dairy were consumed. And you can see pertinent is if they are unpasteurized or undercooked. Are they prepared in situations where they may have come in contact with other issues? And then fecal contamination of food or water, such as hepatitis A. Other exposures would be animals, farm animals mainly, travel, occupation, and daycare. Time history is very important as well. As you can see, the differentials related to time of ingestion would lead us to different microorganisms. Diagnostics labs are not routinely needed unless we have concern for volume depletion. We would be looking for hypokalemia and renal dysfunction on a metabolic panel. CBC would include bacterial etiologies, may be able to differentiate BTINR. If there's a concern for identifying hemolytic uremic syndrome, BTINR would be important, as well as maybe hemorrhagic E. coli. Blood cultures if there's fever or systemically ill appearance of the patient, and then hepatitis A if there's any concern for that fecal oral contamination. Stool testing is indicated in all of these symptoms, such as profuse watery diarrhea, volume depletion, greater than 6 stools in 24 hours, severe abdominal pain, concern for a need for hospitalization, and we'll talk about that in a minute. And then temperature elevated greater than 38.5 or bloody or mucus diarrhea. There are some high risk situations that do need to be considered. Patients that are greater than 70 years old with cardiac comorbidities, immunocompromised, or inflammatory bowel disease history. Are there greater than 1 week of consistent symptoms? And are there any public health concerns that alerting may need to be performed if the stools come back positive? So, stool cultures will identify the more common Salmonella, Shigella, and Campylobacter, as those are the three most common causes of diarrhea in the United States. However, you may need to specify if you are looking for other antigens such as Yersinia, Aeromonas, Vibrio, or Listeria. If a stool specimen cannot be performed or retrieved, then you actually can perform a rectal swab. PCRs are going to evaluate for enteric pathogen nucleic acid, and that is actually preferred testing. Stool antigens will also be elicited with that. Ova and parasites. This is low yield and requires multiple specimens, but is indicated if we have a concern for traveler's diarrhea and watery diarrhea greater than 1 week's time frame. Fecal leukocytes and stool guaiac will also be important, denoting whether there is blood or leukocytes present. Interventions. We would look at volume and electrolyte replacement as indicated. Most times you are going to do oral rehydration, and this should contain glucose as it helps water reabsorption as it is an osmotic agent. Dietary guidance. Rat diet is something that we always recommend, but it's not actually evidence based medicine, but it may be helpful because they are low residue. Avoid provocative agents such as sorbitol, lactose dairy, and caffeine. Admission criteria for the hospitalization related to acute diarrhea includes very young or very old, severe with hydration issues, severe comorbid illnesses, high fevers, and intractable vomiting that is present in addition to diarrhea. Pharmacology is going to include any of the mentioned lists here: probiotics, zinc, loperamide, Pepto Bismuth, antibiotics, depending on what the cause is. Looking at prevention, obviously, if you have patients who are traveling, then vaccinations for common issues, especially in endemic areas, would be important: rotavirus, typhoid fever, cholera. Follow the mantra of boil it, cook it, peel it, or forget it. If you cannot maintain that of most of your foods and drink, do not consume it when you are out of the country. Prepare your own foods compared to those with street vendors. Keep bottled water. Alcohol does not disinfect as much as we would like it to, and freezing does not disinfect either. Food and waterborne prevention: hand washing, hand washing, hand washing. Also, do not return to work until 48 hours after symptoms have resolved, and that is pertinent for food service as well as healthcare. Check foods for safety, proper temperature, avoid cross contamination, don't drink the swimming water, or if you are in any areas that may have children who swim in diapers, that is also problematic, and avoid any watering areas that have strong odors or the water does not look the best. So let's just take a look at a couple malabsorption etiologies. So malabsorption syndromes will affect altered or are an effect of altered digestion, chronic fatty diarrhea. And basically there are multiple etiologies that impaired nutrient absorption. It is often more associated with chronic diarrhea and will result in nutritional deficiencies. And then treatment will be targeted at correcting the underlying disorder. So your etiologies include Whipple infection, pancreatic insufficiency, celiac disease, impaired fat malabsorption, tropical sprue, lactose intolerance, bile salt, short bowel, and drugs such as orlistat or acarbose. So clinical features of malabsorption syndromes include frequent loose watery stools, maybe a lactose intolerance, or pale, bulky, foul smelling, which is more indicative of a fat malabsorption, abdominal pain and excessive flatulence, bloating, weight loss, nutrient vitamin deficiency. And if symptoms improve within 1 to 2 days of not eating, that is a big historical clue because that means that food is a trigger. Potential vitamin deficiencies: folate, vitamin B12, vitamin K, vitamin A, iron, and copper are pertinent. Historical clues would be anemia, chelosis, painless glossitis, angular stomatitis, hematoma, bleeding disorders, night blindness, follicular hyperkeratosis. Diagnostics that you're going to perform in the workup of a malabsorption include CBC with differential, looking for your anemias. Iron studies would always be good to pull. Electrolytes, obviously evaluating your magnesium, calcium, potassium, albumin, vitamin D, stool staining, 72-hour fecal fat test, lactose, hydrogen breath test, D-xylose absorption tests, and stool chymotrypsin are all going to be aimed at identifying if it is fat malabsorption, pancreatic insufficiency. Imaging would include CT abdomen or colonoscopy with biopsy or a barium transit study. I have a picture here of a barium transit study. And what this is revealing here is a reversal of the fold pattern. And you're going to see more prominent folds in the ileum and bald appearance in the jejunum. And that is caused by the atrophy. This is consistent with a celiac pattern. Malabsorption interventions and monitoring include treatment of that underlying cause, potential use of antibiotics, and enzyme replacement. Lifestyle would include dietary restrictions based on the malabsorption syndrome that is present, nutritional supplements as needed, and then monitor for recurring deficiency, and you will perform bone density testing. Let's take a closer look at celiac disease. So this affects approximately 1% of the general population and may present at any age. It is characterized pathophysiological by mucosal inflammation, villus atrophy, and crypt hyperplasia. There is a varied presentation, but usually includes diarrhea, failure to thrive, iron deficiency anemia, and osteoporosis. It is an autoimmune disease process. It has positive immunoglobulin A tissue transglutaminase serology. And this also is then going to be confirmed by duodenal biopsy and histology. Complications of untreated celiac disease are ongoing gastrointestinal symptoms, malabsorption. There is an increased risk of malignancy and a higher overall mortality in the undiagnosed patient. Your clinical presentation would include weight loss, discomfort, bloating in the abdominal area, anemia, easy bruising related to nutritional deficiencies, osteopenia, osteoporosis, fatigue, peripheral neuropathy related to B12 issues, large, bulky, foul smelling stools, ophthalmos, stomatitis, or dental enamel hypoplasia. Other key factors are family history of autoimmune diseases or personal history of other autoimmune diseases such as type 1 diabetes, Hashimoto's, or Graves' disease, failure to thrive, immunoglobulin A deficiency, and a history of genetic Down or Turner syndromes. Your diagnostics specific to celiac disease, in addition to those malabsorption, would include autoantibodies to tissue transglutaminase, immunoglobulins, IgA or IgG, and endomysial antibody, which is abbreviated EMA. Also, antibody to gliadin, and native gliadin is AGA, IgA, IgG. Deaminated gliadin peptides, IgA, IgG, DGP. Genetic testing would include HLA typing, and that is that human leukocyte antigen, which is the common genetic link through many of the autoimmune processes. Again, your CBC and blood smears, electrolyte, LFTs, and renal function. Imaging, small bowel endoscopy, and DEXA scan later related to potential osteopenia, osteoporosis. Others would be a gluten challenge, and you can initiate this as you are doing the workup. Intervention, celiac disease, which includes a gluten free diet. Replace your electrolyte and your vitamins and minerals appropriately. And then, if it's refractory disease, indicated for referral to dietitian and gastroenterologist. Okay, that wraps it up for the approach to diarrhea. Both acute and chronic have been discussed, and hopefully you understand the differential diagnoses as well as the workup and understanding why the tests are drawn that are needed.